This session is ready to begin. Katie McGraves-Lloyd from OnPoint Health Data will moderate this session. We also want to recognize our sponsor, the Mercatus Center at George Mason University. Katie, the time is yours.
Thank you, Norm. Hi, my name is Katie McGraves-Lloyd, and you are attending the session, Building a Broader Vision of Healthcare Data, Thinking Outside the Box. Thank you for attending the final presentation of the conference. As a reminder, please chat your questions in the Q&A box. We have a full session today with 4 presenters, so we're just going to start without delay. First to present are Liz Davidson and Jennifer Winter from the University of Liz and Jennifer.
Thank you very much, Katie. And thanks everyone for the opportunity to present our work here. We welcome very much our feedback on this work in progress. My name is Jennifer Sunrise Winter, and I'm here with my colleague, Elizabeth Davidson. We also have on our team Victoria Fan, who is a NADO attendee in the past, but is not here today, as well as 2 wonderful research assistants, Crystal Boyce and Crystal Lopez. So to get started, excuse me. So our research project really is looking at the ways in which health data are a critically important resource for health policy, service delivery, and system improvement, something that we all know. But health data are also an incredibly tough challenge to govern effectively. And it takes organizations with highly trained and dedicated staff, like all of you here, to do so. And so our research project is focused on how these organizations, come into existence, the why, when, and how of this. So 2 years ago, we were awarded an NSF grant to study these very questions. And we've decided to focus specifically on APC developments within the United States as an exemplary case. We've been able to tap into the expertise and experience of many in the communities that support APCD developments, in particular NADO and the APCD Council, which have been wonderful resources for APCDs that we've learned a lot from, as well as many leaders of the state APCD organizations, as well as consultants and vendors, many of whom have participated in interviews with us. So we'd like to thank all of you at this point for all of your valuable time and information that you've been able to share with us. We'll be finishing our data collection this fall and pulling together our analysis and initial reports for later this year. And so without too much delay, I'd like to just begin with some of our research insights. So you may have seen a map like this one before at the APCD Council website, which summarizes developments in the states. We use their information as a starting point. And so thank you very much, those of you who had worked to develop this, to delve into state level documentation through our interviews. And what we're trying to understand in our project is not only the current status of APCDs, but also the variation within and across APCDs. So we were warned very early on at NADO that each APCD is unique in some way. And so we're looking at why is this true? What we've learned, of course, is that this is a type of data governance organization that has continued to evolve and has such variety. So this map highlights 2 areas of this variation. First, the overall status, ranging from well-established all the way to never got started. We also can see from this map that about 55% of states have an APCD-like organization. And so we're curious about why this is the case. What we've learned is that there's no simple or obvious patterns. Second, this map shows what type, if any, of regulatory authority exists to mandate the claim submission versus voluntary. And so what we're really trying to understand is how does this variation influence how APCDs continue to evolve in both their mission and their impact. And so there's many other variations and similarities that we've been studying. And at this point, Liz is going to discuss some of our other preliminary findings.
Okay, thank you, Jennifer. There are a number of differences in how APCD organizations are structured. With our very limited time, I'm going to focus on just a few key points and leave the rest for discussion. The chart on the right highlights 4 APCD organizational types. Most APCDs are either a department within a state agency, often the Department of Health, or an independent state agency. We've seen 5 that are independent not-for-profits, but are designated by the legislature to act as the state APCDs, as well as several states that have not-for-profits acting like an APCD, but without that legislated role. APCDs differ quite a bit in the breadth of data that they collect, as well as their data release and use policies. There are similar structures as well. For example, the types of oversight and policy committees that work with the APCDs as part of the governance. In our project, we're trying to explain why this variation happened and how variation affects APCDs individually and collectively. And of course, we start with the idea that each state is very different. However, the timing of when an APCD was established early in the process or more recently seems to be one factor in how broad and open the APCD's mandate is to function. Also important is who were the champions in the state government at the time the APCD was established. For instance, was the impetus coming from the health department or from the insurance commissioner and the insurance division? Similarities in structures are advanced through sharing best practices and new APCDs learning from the more established ones in forums like this NATO conference. Next slide, Jennifer. There have also been a number of external factors that we're trying to understand that have influenced how APCDs collectively have developed. Over the approximately 20 years that APCDs have been developing, states have been taking a stronger regulatory role in the healthcare marketplace overall. And of course, APCDs are intended to provide the data for policymaking and policy evaluation. Of course, passage of the Affordable Care Act in 2010 increased states' regulatory roles in individual marketplaces, particularly around rate regulation and pricing transparency. A series of CISIO grants in the 2012 to 14 years helped a number of APCDs either get started or expand their efforts to address particularly these two issues. Although the Gobet case really caused a shudder in the force, and we could say, for APCDs, APCD organizations have adopted quite well to this loss of ERISA data by understanding what it means, and they continue to support analytic requests as well as reporting. Community initiatives by NATO and the APCD Council, as well as various states that are working together in some particular projects, working with common consultants and infrastructure vendors, tend to lower the learning barriers for new APCDs to get started through this experience sharing. So I say lower the barriers for learning, but not necessarily lower the barriers. One implication of these external forces is that new use cases can take shape and spread across the APCDs. This year, we've been seeing and watching how the APCDs are tackling the COVID crisis, for example, to look at how the shifts in funding and demand within the marketplaces are affecting what's happening. Next slide. So there are a lot of variety in the types of use cases for the APCDs. Use cases result in various data products that APCDs produce, like a public release file, requested data extracts, some standard reportings, and so on. Many of these use cases relate to this basic rationale for the APCDs, which is evidence-based policymaking and regulation, understanding what's happening with insurance access and coverage and so on. The developments from the consumer-facing price transparency websites were very closely related to the ACA and CISIO funding, grant funding, and we see some interesting developments. We saw those in previous NATO conferences. At this NATO, we've been in a number of sessions that show how different types of data are now being integrated with the APCD claims data to try to drill into healthcare marketplace issues or challenges. These efforts are really hard, of course, due in part to the need to link data, which sometimes is limited by regulations within the state, the timeliness of the feeds, difficulties accessing data, even from other state agencies. Several sessions presented here, including the ones I just sat in right before our session, explain how data analysts are overcoming these barriers to build new types of data repositories and reports that really do broaden the use of this data. Jennifer, we're going to turn back to you.
Thank you very much. So as we noted, this is an ongoing study, and we very much welcome your thoughts. In terms of challenges, I think the things I'll mention here, actually for those of you who are on the ground, these are going to be already very well known, but I think we still want to highlight them. Clearly, payment reform is questioning the value of claims data. Also, we've been observing a lot about the tensions that surround national standardization. So on one hand, the benefit of reducing the submitter effort, but also losing individual states' special developments and interests. In terms of opportunities, a lot of what we've been observing, first of all, is that there does appear to be a continuing need for APCDs, and that there's a lot of new types of technologies that are being used to make them more effective. So for example, Liz just mentioned the data linkages, things like hashing, and certainly machine learning and so forth. So with that, we just want to again welcome your feedback and thank you very much for attending our session. Any feedback in particular about the opportunities and challenges that you see for APCDs now or in the future? Areas of change are of particular interest to us, or any just comments on what we found so that we can continue to refine and or correct any of our information. So we have our contact information here. We welcome you to join us now in the short question and answer session or later via email correspondence.
I see a comment from Ken, thank you, that New Mexico is in the RFP process. And so thank you for that update. We realize that some states that were charging ahead have stumbled over the COVID crisis and the lack of funding and the attention to COVID. So that's a good update. Thank you. Do we have other questions? Anything you'd like us to go back to? Okay, so we see Nevada PPC just voted last week to seek legislation. Okay, thank you.
Thank you very much.
One of the things, you know, the great things about attending NATO and meeting other people in the APCDs is some of the people we talk to, like say, it takes a long time from legislation to APCD in terms of years. Any other questions? Can you put the timeline side up again? The timeline, I think that's back a couple, Jennifer.
Okay.
Brian, did you have a question? You're showing up as there. What we're
no, let's just testing the mics.
Oh, okay. What we're trying to get across is, you know, we are academic researchers. My area is, I'm in a business school, but I'm also interested in kind of organizational developments, how organizations develop and why they develop. And so we're looking, you see on the far left of this slide, we're trying to abstract what are the kinds of external forces. So these community initiatives are covering things like, you know, the APCD Council and their conferences, the integration of APCD and NATO in these kinds of sessions, as well as, you know, specific activities like data standards that help move the movement as a whole. Regulatory change, we just highlighted a couple here. The other would be, you know, towards the alternative payment models and so on. So that's what those big arrows on the right are trying to indicate, that these are general kinds of influences that are affecting how the whole group of APCDs are developing. And you can see we gave the GoBay their own special arrows. That was, our project started just after GoBay, and we can see that there's still discussion of how that impacted the APCDs and what they're doing to deal with that. Yes, we all have a comment. Oregon has 2 APCDs. That's true, and that's one of the reasons we've looked quite a bit at Oregon. There have been both APCDs represented here, and we see those as being very interesting contrasts in forms about where they get the data, who their primary constituents are, and I think there's quite a bit of overlap there. I think also the state of Washington for a time had voluntary, they're moving towards a state agency, California the same. So thank you for that, pointing that out. We're actually on one of our earlier slides, Oregon shows up twice, once as a voluntary not-for-profit and also a mandated state agency. And that's one state where the 2 forms are coexisting. All right, Katie, I think we probably have run out of questions. Maybe we should turn it over to the next group.
Yes, thank you, Jennifer and Liz. Next, we have David Stern and Brian Williams from Stern Consulting. David and Brian.
Thank you, Katie. Give me a minute to get my slides up here. Okay. So thank you, Katie. And thanks to everyone who's joined us here. I think we have 70-something people in the room and more joining. We're delighted to have you all here with us today. I'm here with my colleague, Brian Williams, who will be talking in a few minutes. And we work for Stern Consulting. We're a company that uses information to improve healthcare performance. And like a lot of you, we've got a bias towards using administrative data. But we were very excited when we saw that there was a panel in this conference that was thinking outside the box, building a broader vision of healthcare data. Because for us, our sweet spot has been administrative data. But when we started some time ago to look at the broader world of national healthcare policy, it became clear that admin data alone would not do the trick. We had to widen our horizons by a lot. So today we're going to share with you some of what we've learned of the broader universe of healthcare data. We'll present a process for sorting through that universe and a case study with some specific examples. Brian?
Thank you, David, and hello to all. In trying to put a figure on what's out there, we've identified over 3,500 data sets, some of which we've named here. Whatever the actual number may be, it's certainly growing. So we thought it would make sense to have a framework to sort through it all to get to the few data sets best suited for a particular project. And here's that framework. There's 3 parts. The what's out there part, the universe, is on top. The what am I looking for part, the project criteria, is below. And that includes things like whether the data are relevant to our project objectives, accessibility, and appropriateness of the source of the data, excuse me. Down the left and right sides, we have the 3rd part of the framework, the data dimensions. These are the characteristics that enable us to understand the data universe in general and to identify the particular data sets most suited to our requirements. They're essentially the links between the project criteria and the data universe. Now, in some cases, those links are quite direct. Note the connection between the relevance to objectives criterion and the content dimension. If access to care is the subject of the analysis, then the selected data sets must have access data. Likewise, there's a connection between accessibility and the constraints and use dimension, and appropriate source and the sponsor dimension. Now, in the upper left, notice that the granularity and the mechanism of data generation dimensions are less bound to the particulars of a given project. Now, that's good. This means there is more flexibility and opportunity in choosing data sets within those dimensions. So now let's look at the framework in the context of our case study. In selecting data sets to evaluate the impacts of national health policy, we had 4 requirements. The data must address access, cost, or healthiness, be publicly available pre and post implementation of the ACA, be national in scope, and be reflective of the population as a whole. And that means not limited to those who have engaged the healthcare system. The highlighted areas represent those requirements. Now, as David said, having used administrative data as our go-to solution for most projects, we compared their characteristics to our project requirements. So here we see the admin data characteristics within each dimension in the blue text. Our project requirements are highlighted in orange. The orange areas without the blue text show the gaps. Note the gap particularly in the areas of access and health status under the content dimension. Also under the unit of analysis dimension, note that our case study deals with person-level impacts for the population as a whole. And yes, while some admin data does include person-level information, it is by definition limited to persons engaged with the healthcare system. Now, the good news for our case study and apropos for our discussion today is that all of the elements in these circled areas represent opportunities outside of the box of administrative data, and they are substantial. Getting back to our particular case study, 8 particular data sets made the cut. And here are those 8 down the left-hand side, broken out by our 6 key dimensions across the top. We're not going to look at each dimension, but let's take a closer look at 3 of them. Starting with the mechanism of data generation. Note that 6 of the 8 are surveys, clearly outside the box of administrative data. In terms of the granularity dimension, we tend to prefer microdata because they provide the most flexibility. However, macro data can be quite substantial. Some of our selections include not only tables and other pre-aggregated formats, but online tools enabling users to directly query the underlying source data. Now, regarding the content dimension, 6 of the data sets are clearly focused on health care. But we can't overlook the non-healthcare focused data sets, ACS and ASEC. They include extensive demographic, social, and economic drill down capabilities for the health-related variables that they do provide and may be linkable to other data sets for similar purposes. Let's take a more detailed look at the content dimension. Here we have a count of the variables in the body of the chart by content category down the left side for each of our data sets across the top. The green boxes represent the most robust resources for each subcategory of content. For example, 2 of our data sets, MEPS-HC and NHIS, stand out as being exceptional in the ability to get care. NHANES is the only one to include clinical results. And you can likewise determine the strongest data sets for every other subcategory of health care and non-healthcare data. So that's our overview of the 8 data sets. I'm going to send it back to David to present some sample data from those selections. David?
Thank you, Brian. Our first example comes from the American Community Survey. The survey overall addresses a wide range of demographic and economic factors, and it has only 2 healthcare variables. But it provides excellent drill down capabilities for those 2 variables. Incidentally, those 2 variables are disability rates and health insurance coverage. The chart you see gives a good example of the drill downs. It shows disability rates over time. The light blue and green lines in the middle of the chart represent the US overall and New York State. And you see that the rates have stayed fairly constant for both the US and New York State. Where the data get more interesting is when we drill down to the county level, and we've called out 3 counties here. You see urban New York County in red and suburban Nassau County, dark blue, both have lower rates than the state. But at the top of the graph in purple is rural Sullivan County. It's substantially higher than both the state and the nation rates and is trending notably upward. It's an interesting tendency and one that demands further investigation. A good example of the drill down capabilities of the ACS. But now let's look at the next data set, the National Health Interview Survey. NHIS is the main source of information on the health of the US population. It's rich with data on access, utilization, insurance, and the like, and it's particularly strong in demographics. Here we look at a specific data point, work days due to illness. And we look at it before, during, and after implementation of the ACA, the Affordable Care Act. The columns on the far left, you can see are for all employed adults, and it's good to see that the trend is downward, fewer days lost to illness. But the story gets more complex when you look at race and sex. For the African American community, the downward trend is particularly strong. But for the Hispanic population, especially Hispanic women, the trend is just the opposite. This is the type of drill down that NHIS excels in. Now, we profiled 8 data sets. I just showed you 2 samples. There are overviews and samples from the other 6 in the appendix of our handout, which we encourage you to look out. For what it's worth, the handout also has pretty pictures of Brian and me with some bios, and that's always fun to look at. But for now, we'd like to wrap up with some summary thoughts on choosing among healthcare data sets. So first, think broadly. Healthcare is a complex system with many players, virtually all of whom generate data. Second, Filter wisely. Don't reject data sets just because they're viewed as non-healthcare or because they're macro in nature. And lastly, if you're interested in big picture healthcare trends, consider the 8 data sets that we came up with. They're excellent data sets. Thank you, and that concludes our formal presentation. If anyone has any thoughts or questions, we would be delighted to take them now.
Great, thank you, David and Brian. Our third presenter is Ann Mednes from the Massachusetts Center for Health Information and Analysis. Ann?
Hello. Okay, good. Hello, my name is Ann Mednes from the Center for Health Information and Analysis of the Commonwealth of Massachusetts. I'm presenting the paper on examining the pattern of utilization of hospice services using the Massachusetts All Payers Claims data. Next slide, please. We started by examining the research on hospice services, and it became very clear early in our research that most researchers use the Medicare fee-for-service data or the surveillance, epidemiology, and end results Medicare data. There were a few that used case studies of actual hospice service centers. So it occurred to us that it could be necessary to see how the APCD, the All Payers Claims data, could be used for examining hospice services. So this study used the Massachusetts All Payers Claims data to examine the utilization pattern of hospice services among all payers, because the Medicare population happened to be the population of interest in all the other studies we saw when we did our research. Next slide, please. We used our Release 7 All Payers Claims data. That's the 5-year data from 2013, calendar years 2013 through 2017. And in order that we do not have any duplications, we use the highest version 1. Highest version 1 is the highest version of the data that was paid. There are other versions like 0, meaning the highest version was not used, and then 9, meaning it was not versioned. But the highest version paid is highest version 1, and that's what we used. So first, in order to get all the hospice-related discharges from the version 7, from the Release 7 version 1, we used these we use the discharge status, the site of service, the insurance type code product, and the distinct member link ID variables. After pulling these out from the data, we use the resultant data. We stratify the resultant data according to the discharge statuses. 50 meaning discharged or transferred to hospice, 51 meaning discharged or transferred to hospice medical facility, 40 meaning expired in hospice, 41 expired in medical facility, 42 expired, place unknown but hospice indicated. Then, in order that we do not lose sight of any other hospice-related discharge, we also included discharge to home or self-care, 30 still a patient or expected to return, and 70 discharged and or transferred to another type of healthcare facility, where in each of these three cases where the site of service is 34. Site of service 34 is hospice. Next slide, please. Next, we stratify the data according to payers, and we group them as government or not government payers, and also the facility related discharges, in order that we'll be able to compare the two. We also separated facility related discharges from non-facility related discharges across the different sites of service. Next slide, please. So from 2013 through 2017, we saw an increase increase in the discharges, which spiked in 2015 with a sharp decrease in 2016, which was followed by an increase again in 2017. We attribute this finding to the 2016 Supreme Court decision on Gobey versus Liberty Mutual Insurance that the Vermont state cannot require ERISA protected health plans to send information that describes all healthcare procedures. Because after that decision, many ERISA protected health plans stopped sending claims data to the Massachusetts All Payers Claims Data as a result of the decision. Next slide, please. When we looked at insurance type, comparing government versus non-government insurers, we saw a percentage of non-government, the percentage of non-government payers spiked in 2014, which was followed by a downward trend in 2015, and a slight increase in 2016 and a decrease again in 2017. In reverse, the percentage of government payers decreased from 2013 to 2014, followed by an increase in 2015 and a slight decrease in 2016, and a subsequent increase in 2017. In the graph, the blue lines represent government payers and the orange line represent non-government. There was an other category which did not really matter much, but we needed to include it to show that there is a difference. Next slide, please. Okay, so when we looked at non-government payers, we had to include all the self-pay, the indemnity, the point of service, the preferred provider organizations, the health maintenance organizations, and the EPO, exclusive provider organizations, under non-government payer category. And the government payer category, we included Medicaid, Medicaid managed care organizations, Medicare Pass A, B, and secondary plan, and also Medicare Advantage. We also included Commonwealth Care and Commonwealth Choice, which are the state of Massachusetts plans. Then we also included the Veterans Affairs and another category called Other Federal Plan. So all those made up the government category of payers. Next slide, please. Okay, so when we looked at the percentage of live hospice discharges, comparing non-facility versus facility, in this graph, we are showing the non-facility in the orange line, and the facility-related discharges are shown in the navy blue. What we found was that the non-facility related live hospice discharges constituted about 2/3 of discharges all 5 years with an average of 68.14%. Then in the next chart, you see the annual percentage of hospice deaths, hospice-related deaths. And we found that it's the reverse of the live hospice discharges. We found that facility-related hospice deaths constituted an average of 69.58%, more than 2/3 of all hospice deaths during the 5-year period. In addition, we saw dramatic increases and decreases in the live discharges in 2015 and 2016, when the percentage of non-facility discharges spiked with a corresponding decrease in facility-related discharges and vice versa. So next slide, please. And the next one. So we concluded from these findings that the use of the Massachusetts All Payers claims data rather than the Medicare claims data serves to study groups of patients across healthcare systems. So we recommend that further studies should be done to shed light on the relationship, if any, between the proportion of deaths and the site of service. So that concludes the presentation. I look forward to any questions you may have.
Thank you, Anne. I have not seen any questions come through the Q&A box. Just a reminder to the participants, please feel free to chat in your questions to the Q&A box. Now we are ready for our fourth and final presenter. Our next presenter is Kofi Ampabang from the Mercatus Center at George Mason University. Kofi?
All right, thank you. Can you see my screen?
Yes.
Good, okay. All right, thanks everybody. Hi, my name is Kofi from the Mercatus Center at George Mason University. And again, I have to say thanks to all of you for really thinking outside the box. Very interesting presentations. And so to continue on our theme of thinking outside the box, I am gonna present a new data set that we call Health Reg Data. It is very different from All Payer Claims Database, but it is useful for research, we hope, and we hope that you will actually be able to use that. I'm from the Mercatus Center at George Mason University, and our goal is really, with the Open Health projects, our hope is that over time, US healthcare will get better and cheaper for everybody, and through a combination of policies, both at the federal and state level. And one way to do that is to encourage innovation in healthcare and increase the supply of quality healthcare. It's really what we need. So I'm going to proceed by first giving a quick overview of what this whole reg data is about, and then how we do it, how we create the data. So basically we are creating a new data set that we want to share with the research community. And then I'll give you a peek of how the results look like. And then finally, some of the possible uses for the data if you find them useful. So what is health reg data? Well, we all know US healthcare is complex and expensive. I mean, I'm preaching to the choir here. Unfortunately, compared to our compatriots in OECD countries, our outcomes aren't as great as how much we spend on healthcare. And if you trace the evolution of our current healthcare system dating from the 1920s, all the way up until now, when the AMA got involved in terms of regulating or at least establishing standards for medical professionals, there's always been that symbiotic relationship between the regulations and outcomes. So there's a disaster here, a government agency steps in to try and correct it and issue regulation here. The participants adjust one way or the other to that, and then we have to keep correcting that with new regulations, or at least undo things. So there's been that evolving relationship between healthcare and health outcomes in a system, resulting in what we have now. And so these are some of the examples of the regulations that we have on our books, right? We have regulations that pertain to drug approvals, to medical licensing, scope of practice for medical professionals, if you're familiar with that, as well as insurance benefits. And these are just examples of some of the regulations that are over there, on our books. So to bring us back, have you ever wondered how many regulations there are on the books, or what are the types of healthcare regulations do we have? Do we even know where to find them? How do these regulations differ across states? And do you think that these regulations have any role in healthcare outcomes, either healthcare inputs? We don't know. Basically, what we're trying to do is to create a data set that would help researchers answer these questions without taking any position whether they're good or bad. And so our goal is to, first of all, quantify the information about healthcare regulations from the regulatory text. So that's really the innovative piece that we bring to this conversation. And what we do is that we use the regulatory text for every state or jurisdiction directly to create these data. So we do this in a number of steps. The key things we're going to do, or at least I'm going to talk about over the next few minutes, is first of all, where and what are healthcare regulations? And once we do that, we say, let's quantify these healthcare regulations. After we quantify these regulations, and I'll talk about the quantification metrics a little bit later, we then want to classify these regulations. Can we tell which industries, which professions, whatever, are affected by these regulations that we found, and who basically has to respond to these regulatory? And then we can also put them into topics, either these are regulations that cover pharmaceuticals, scope of practice, or licensing, etc. So a brief summary, we've done this for 44 states in the DC. For 6 states, we don't have the data for various reasons. Either they don't have the written code, or it's difficult to get the data in order to do that. We're doing this for federal as well. And so you are able to see, I don't have that output today, but what we are able to do is that you can actually see the evolution of healthcare regulations between 97 all the way through to 2020. So for every year, we have the healthcare regulation, like the stock, and we've, as I will describe in the algorithms, you actually see how we generate the data from that. And so you can see from year to year how things have evolved between 97 up until 2020, when the CFR, the Code of Federal Regulations, became online and available. And for some states, I went ahead, that are very good at keeping their regulatory codes. For a place like Idaho, you can go back to 97, 96 actually. Indiana, I think you can go back to 2002, Kentucky, 2012. So for these states, we actually have data for every year from these dates that I mentioned all the way up until 2020. We can run these analyses on their data. So how do we do this? So first of all, I mentioned we want to identify healthcare regulations, quantify them, and then basically classify them, right? So these are the 3 things we are aiming to do. And we do that with machine learning and text analysis. So the first thing we want to do is gather the data. And so we have a team that have been able to collect all the regulatory code for every state, well, those that we are able to, as well as the federal government, into a large repository. And then the next step is then to determine what's the unit of analysis. And this is key. For example, if you're in a state like Maryland, where Title 10, I believe, contains a lot of our healthcare regulatory code, then you have subtitle in there. So every subtitle would deal with a different topic within healthcare. And then finally, you would have, say, the chapters. And obviously within the chapters, you would find subchapters or sort of sections within there. What we decide is that the title, subtitle, chapter combination is a good enough unit of analysis. So whenever I use the word document going forward, I'm referring to this title, subtitle, chapter document in, say, a state or any state for that matter, and states name them differently. And on top of that, we then proceed to define healthcare. What is healthcare? And this is also key. Is it regulations that are aimed at environmental safety? They affect your health, but they are not exactly regulating healthcare. We are interested in the things that impact the provision of healthcare services. And so professional licensing is important. Certificate of need laws are important. Drug approval, pharmaceutical formulary. These are all things we define as healthcare. And so what we're going to do is that we're going to train an algorithm to go in and find these things and classify them as healthcare. And once we do that, we have what we call the process of creating training data. And since we don't want humans to sift through 300,000 documents, we need to just get a good sample, teach the algorithm how to do it so that the algorithm can actually go there and find these regulations across all codes. And so that's the training data. The training data is that we pick a sample and show the computer how these ones are done. And that's point 4. Then once we do that, point 5 is where we say we determine the probability that a document pertains to healthcare. So the example I gave you that in Maryland, it is title, subtitle, chapter. We have a bunch of them, right? And so the algorithm is going to pick each one and say, is this healthcare or not? And what is the probability that it's healthcare? So if it's 1 or 100%, it means that I'm very certain that this document is regulating healthcare. Anything below that, the certainty reduces. And then we have another set of algorithms that say, now that you've identified a regulation, what industries do they apply to? And so we use the NAICS classification to then apportion all these sort of that are most likely to be affected by these regulations. Then the 7th step is really what we call the quantifying the restrictions. And here a little bit of explanation also helps. Regulations by nature impose obligations for you to do something or stop you from doing something. And so based on that fundamental understanding, we've said, okay, we've defined a concept we call restrictions. Okay, it's either restrictions on the agency, on the government, or the individual, or the public, we don't care. All we're saying is that if you come across the terms shall, must, required, prohibited, and may not, they pertain to a restriction or an obligation that the government is placing on somebody. So that becomes our measure of restrictiveness. So how does it look like after all these things that I've talked about? Well, look at an example here. So after applying our algorithm, we said, Oregon, for this particular document called hospice services, our algorithm was very certain that it regulates healthcare. So it has a probability of 1. And it was issued by the Oregon Health Authority. And it contains 72 restrictions. Similarly, in Maryland, there's a document titled Responsibilities and Accreditations and Audits. It's issued by the Maryland Health Department, and we are 95% sure that it's healthcare. And it contains 21 restrictions. And if you look down, the next highlighted again in Maryland, you see boiler rules, board of boiler rules. And the algorithm is like just 3% that it's healthcare, so it's really sure it's not healthcare. And then you have this threshold where we say, okay, if this probability is above a certain level, we actually then classify it as healthcare regulation. And so once we get all these data, we summarize them into these examples. So now you can see that in total, for all states, there are 800,000 restrictions, and they comprise 13% of all the restrictions across the state. And then you can have the same information then summarized for every state. So the number of restrictions, and we look at just the number of words that are in the whole code as well. Then finally, we classify them into industries. So the first thing you would see is that 1/4 of all regulations actually apply to the ambulatory healthcare services, which makes sense, right? The provision of healthcare services in these outpatient centers. And then there are a few higher raises like administrative support services, but if you understand the nature, the way NAICS classifies codes, there are a lot of industries that are sort of tangentially related and so on. And what can you use these data for? Well, so many things. One of the things we do is you can combine them with so many other data we've looked at, so you can even see how regulations impact the APCD. ARC has a lot of data, Medicare claims data. And you can basically just use it to find regulations. If you're really interested in where are the regulations, how can I find them? You can actually look at these documents and see the titles. We provide all these data for you to look at. And so here's one quick example where we said, for all these states, for Alabama, 21% of their healthcare regulations actually apply to the ambulatory healthcare. It's 43% in Colorado, only 16% in DC, and 20% in Florida. And so with that, I've come to the end of my presentation. You can find out more at the MedCare's website. And if you want, you can also send me an email if you have any questions. Thank you.
Thank you, Kofi. So I'll just pause. I haven't seen any questions come through Q&A.
John Friedman had his hand raised. I don't know if that was for a question or not. You might want to, if he has a question, ask him to type it in the box.
As a panelist, I don't seem to be able to type into the question box, so I just will pose a question to Kofi. Very interesting research, and very impressed at how you can deal with this amount of text to analyze it. I'm curious, do you think you could drill down even further in the future towards data use type restrictions? One of the complexities in healthcare is figuring out where are all the restrictions on what the data could be used for. And that seems like that would be, you know, obviously want the broader picture for policy, but for specifically for the data folks, it would be interesting to know what regulations specifically apply to data use.
Absolutely. In fact, this is really the very first step. The lab that I had is called the Quantitative Health Lab. Our goal is really to map out all these things in regulations. And so as our next step, we're actually going to be classifying them into topics. We are going to be looking at what regulations apply to drug formulary, what ones apply to data use, which ones apply to privacy. These are all things that are relevant to various researchers, and we aim to actually map out the regulations as to how they apply to each of them and where you can find them.
Hi, as another panelist, can I jump in with a question here? Kofi, fascinating work, and kudos on the goal of increasing innovation by looking somewhat critically at regulation. A question for you. During the current pandemic, some states have started suspending some regulations that seem unnecessary, like not honoring other states' licensure and such. Have you seen any evidence that this will encourage more permanent loosening of unneeded regulations? Is there any reason for optimism there?
So that's a great question. We have, some of our researchers have been speaking to some states to figure out I actually have a pet project that I haven't launched yet, but I've been collecting all these regulations that have been suspended to figure out why, for what reason, and for how long they are being suspended for, and whether they want to be snapping them back in place. I think one thing you've talked about, the reciprocity of licensing, as well as telemedicine. So they've loosened a bunch of these. Some states have snapped them back, unfortunately, and some have also looked closely at doing away with a lot of them and making some of them permanent completely. I don't have the list off the top of my head, but it's something that some states are actually actively engaged in looking at across board, particularly as it relates to telehealth and license reciprocity.
Thank you.
Great. Any other questions from panelists?
Do you want me to activate John as a speaker briefly to see what his question was?
Sure.
Okay. John Friedman, if you're watching, you should be able to unmute and ask your question verbally. He's still on mute. Okay. All right. Okay, Katie, back to you.
Great. Thank you. Actually, Kofi, I just wanted to bring up one more question. If you could bring up your slides.
Okay, sure.
To your second to last slide.
Second to last, okay.
This is where you were listing sort of the distribution by state.
Okay.
And so a question to the panelists, kind of like a use case for thinking outside the box. So this regulation data is obviously not APCD data. So do the panelists have thoughts on how to use an APCD's information in conjunction with regulation information like shown here on this slide?
It seems one thing that you can do, it's, you know, as a kind of research design, is look at a before and after when, you know, regulations were brought in, since, you know, not only identifying the regulations, but the time frame and doing a cross-state analysis. It seems like this would be really helpful to do that. Of course, that would also involve using APCD data across, if you want to do cross states, you're going to have it across states, but within your state, maybe doing it before or after is one approach.
Yeah. So the before and after is very attractive. And one of the challenges we're having with before and after is, apart from those 7 states that I listed, for a lot of the states, we don't have that annual data where you can actually go and look at. We can construct that, but it's going to be a tedious exercise. Now, if my lab gets more successful, I can see us doing that in future, where we can practically may have to basically go down to every state and collect the books and actually scan them and get time sort of stamp kind of thing. It's going to be heavy and on effort, but it's definitely worth it, because just seeing how we've progressed and how policies are changing things would actually be very useful for us just historically.
Great, thank you. So I think we can move to some questions for the group and general group discussion. Again, if participants have questions, please chat them into the Q&A box. I haven't seen any so far. We have about 13 minutes left.
I actually have a question for David and Brian. I mean, great research. In fact, it's just, I find as a researcher, I'm an economist, also a data scientist, it's the data can make one make you. Whether how to find it, spending time to make sure whether it's appropriate or not. And these are all very tedious processes and tasks. Are you planning on making these data available, or it's part of going to be a service you render for people? Like, these are very useful things that you discovered and shared.
So that's an interesting question. We started doing this sort of analysis of data sets sort of for clients, where a client would say, what data sets are out there, how can we use them, and what's the best way, including major multi-billion-dollar pharmaceutical companies and such, saying, what data can we use to help us understand our patient base? As we progressed, we found, among others, that academics were finding it very useful. Where academics, in our experience, will launch onto 1 or 2 databases and say, let me milk this database to get everything I can out of it, as opposed to, there's a whole world of databases that may not come from my comfort level. What can I do with it? So yes, we are certainly considering ways to sort of make public some way of digesting the greater world of healthcare information, not the data itself, but a guidebook to the data, if you will, and we're exploring ways of making that public. Brian, I don't know if you want to add 2 cents to that.
I will just 2 cents, Kofi. On more than one occasion, we've looked at a time or some other chart and said, what happened here? And I can think of a couple of things. We looked at particular states and said there must have been some kind of regulation that went into effect at this data point. So Kofi, you may get a call or an email from us saying what happened in Maryland in 2016. So
okay, no, we'll be happy to. In fact, that's actually my full-time job, is just really reading arcane regulations, which I find interesting. Yeah, if we can, we'll definitely let you know if we can help you.
I see that the work that Jennifer and I are doing is really a kind of a different approach from what David and Brian are doing. Because what we're interested in, there's so much data out there, and how do organizations come into playing to try to get a handle on this data and make them available? And you're looking at it kind of from the flip side. You're kind of like the catalog of what's out there, and we're saying, like, how do different organizations have a piece of that catalog, and what is the piece, and are they viable or not? I think that what's going on right now with in the last 6 months with COVID is pretty fascinating too. The number of data sets that are, first of all, developing not only in healthcare organizations, but even in other kind of organizations, trying to keep counts of the cases and trying to put things together. There's a lot of data governance issues happening right in front of our eyes. Every day when I read the paper, I say, wow, what's going on here? Why did that happen? So I think what you're doing is very valuable in the sets that you're looking at, and it's kind of a different aspect of what we're looking at is like why and how do these data organizations come into play, and how do they sort of make their wares available and that people can find them, and do they have a competitive advantage? Is there a reason for having them?
Liz, one thing that we found is that data that we have ultimately located wasn't obvious. The location was not obvious from the beginning. And it's amazing how many times we stumble across a gem where we're looking for one thing, and all of a sudden here's 3 or 4 other data sets that were related but weren't obvious from the initial question. So,
and I'll say our journey has been very much. We started with all-payer claims databases and MedPAR and other administrative data sets, HCUP and the like. And obviously very rich in the sort of heart and soul of Nato. It is so easy to get lost in the depth and richness of that the concept of almost an infinite array of data sets only tangentially related to those is one that demands further exploration and cataloging, and that's really where we're focusing now.
I thought it was really interesting, a few presentations focusing on this idea of what is health data, and just the fact that there's so many things that can infer health data, and on top of that, they're under different regulatory regimes, right? So some of it is going to be covered under particular state or federal laws, and some of it simply isn't. And so we've got this intense network of data, and then the actors are changing. So it's very interesting in a kind of messy way, but I think that was also highlighted in our presentations today. So,
yeah, very much so.
Yeah. Yes, I thought Kofi's presentation was very, very interesting for 2 reasons. Well, the first reason being the question, what is health data? Particularly a new study that just came out about 3 or 4 weeks ago called All Data Health Data, because you may be answering questions, survey questions that are not health related, but in the final analysis, it dwindles down to your health in one way or the other. And the other part of it was the privacy issues. So when you're looking at regulations, a lot of those regulations come out as a result of some privacy issues coming out. They are all policy related in the final analysis, because they have to protect the data subjects, they have to protect the users too, in a way. So I'm asking you, did you consider bringing together the types of regulations under various categories? What is the main issue here? Not the topic, but what is the driving issue here that brought this regulation to the surface? Why is it out there? Why was it made, you know?
Yeah.
And one other thing, policy issues can also bring some regulations to a sunset suddenly, because if the particular reason a regulation was put out there in the first place is no longer the case, they may have to sunset or just close down whatever name they will use it. You know, they will use to put that regulation out of use. You see, so I know, for instance, I used to work at the Maryland General Assembly years ago, and one of the things we did quite frequently try to see why some regulations that were out there could sunset, when they should, or should we continue with it, get the legislators to reintroduce it under another umbrella that is more relevant at the time. You see, so you may want to look at some of those regulations you came across. Are they still relevant, or are they tending towards the sunset time for the regulations? And here in Massachusetts, I'm part of the group that determines who gets and who doesn't get the data, the case mix data and the APCD for their research. And in doing that, we often have to let people know that the research you are trying to do, you may have chosen the case mix data for it, but you will do it better if you use the APCD. However, we have all these privacy related issues. You cannot get these variables you are looking for, or you probably should use these variables. We sort of hold the hands of researchers who want our data in the first place. So when you are looking at these regulations and the data sets, put those issues in mind.
I mean, that's a great point. It comes with a few challenges. So there's a research I've actually started, but not far advanced. But one of the things we are looking at is, regardless of the outcomes or regardless of the circumstance, if I pick a set of outcomes, like you're saying, whether it's privacy, whether it's health outcomes, whether it's anything at all, is there a way I can actually map that to specific sections, specific content of regulation? I'm actually not sure how that's going to end up, but that's actually sort of gets to what you're trying to drive at. Like, how are we going to be able to attribute something in the regulatory text as relevant to some outcome or something we're interested in? Right? We don't know. I'm still setting that up, but it's a very valid research question that we're trying to sort of understand why that happens. I have a question for Jen and Liz regarding the APCD. I have to confess, this is my first time at NADO, and I'm familiar with the APCD, but never really applied for it, mainly because it's expensive and I'm not even sure whether I'm actually going to get it. And being a researcher, an economist, and a data scientist, I'm always more interested in just exploring to see what's in there before then the research question would evolve. But I find the pricing prohibitive, and I'm really not sure if there's a forum, but to what extent is the availability, the ease of availability of these data going to help drive the move towards the adoption of the APCD all across? Right.
Well, I think that the APCDs, and you have a lot of representatives here at NADO that you can reach out to, they vary quite a bit in their data release policies. And most of the state APCDs charge nothing or very little. They'll often have, say, a public use file, but even for data requests, some of the agencies are very limited by state regulation what they can charge. So it depends what you go to. Like if you look for the not-for-profits, which are actually, their funding sources, data sales, and those data will be more expensive. But a lot of the state agencies, you'd have to reach out individually. That's what we've seen. There's variety in the costs. And, for some of them, like Anne is saying, we do a lot of hand-holding and we help people walk through. Often, some of the states we've talked to, they can't even charge for that. It's not like they can charge a consulting fee. It's like you get to do a data request and we're going to charge you a very little bit of money for the data, even though you spend a lot of time helping them out with that. And then others, it's more expensive. But that is one of our basic questions. We're at about 55% of states have an APCD. When we did our presentation, a few others were saying we're moving forward. And I think that what fascinated us by the APCDs as an instance of data governance is what's the business value, how is it presented, and will it continue to be there? Because these are expensive organizations to set up. And I was thinking when David and Brian were talking, and they were saying, you got to have, what's the question you're trying to answer? APCDs are trying to be available to answer many different questions. Norm, I see you coming up. I think it's time for us to close up.
This time, Katie, do you want to close us out?
Thank you very much for attending. Really great presentations, engaging discussion. Thank you all.
Thank you.
Katie. Terrific
Thank you,
conference.
everybody.
Thank you.